Hi, good evening, everybody. Thank you for joining. My name is Marshall Heradien. I'm a cardiologist here at Netcare Kuils River Hospital and also an EXCO member of the South African Hypertension Society. I will be the moderator for this webinar. Welcome to the SAHS webinar where we will be focusing on hypertension management, a focus on home blood pressure monitoring. Thank you also to Omron for the unconditional support in making this webinar possible. Just some housekeeping rules that I will announce to you. Please post your questions to myself, Marshall Heradien, in the Zoom chat. These will be discussed by the panel throughout the course of the webinar. It is my pleasure to introduce to you Professor Erika Jones, Dr. Lisa Ware, and Professor Brian Rayner. Professor Jones is a clinical nephrologist and hypertension specialist at the Hypertension Clinic at Grootskeur Hospital, and she's also one of the co-authors of the famous Creole study that was published in the New England Journal of Medicine. Erika, it's really a pleasure to have you here with us tonight and to share with us your knowledge on hypertension awareness, treatment, and control. Thank you so much. We're looking forward to your talk.
Thank you, Marshall. That was a very nice introduction. Well, I'm just going to go straight on ahead and discuss awareness, treatment, and control just to kind of open up this evening. And then we will proceed. But basically, just to note, we have this major discrepancy, and this is across the world when it comes to those that have hypertension, so that would be all 100%. And if you look at this across the world, we have this 100% of all those with hypertension and this drop-off throughout those that have actually had their blood pressure measured, those that are diagnosed with hypertension and treated, and then obviously very low rates of control. Now, across the world, we are seeing the drop-off, but it's particularly steep in sub-Saharan Africa. And what we notice is about 7.5% of all patients with hypertension in sub-Saharan Africa are actually achieving the target blood pressures. Now, we need to ask ourselves why. We look at these data, we've looked at the May Measurement Month campaign, and what we see are some quite it's quite a sad picture. So these are data from the May Measurement Month South Africa in 2018, where just over a third of all patients who were screened had hypertension, and only half of those were actually aware of it. Half of the patients on hypertension, who had hypertension were actually on treatment, and less than 30% were actually controlled. Now, yes, we're seeing this. And the reason why I'm focusing on this is it's not just a sub-Saharan African problem. This is an African problem. The other thing about May Measurement Month, this is not a door-to-door, let me go and check everybody in the community's blood pressure. These are the people who are volunteering to have their blood pressure checked. So they're more likely to be a little bit more aware than the vast majority of the population. And then the associations with hypertension are nothing unusual. Now, this is one of the big problems that we have in Southern Africa or Sub-Saharan Africa, is it's not just undiagnosed hypertension, but it's undiagnosed severe hypertension. So just the dark blue is those that are undiagnosed over the total that have hypertension or are diagnosed with hypertension. And this is severe hypertension in the general population. But what I want to notice here is in the urban population, you're more likely to have the diagnosis. And only about 20% of those that are diagnosed with hypertension actually have severe hypertension. So severe hypertension, we're talking greater than 180, 110. In the rural population, 50% of those people with hypertension have severe hypertension and are undiagnosed. Now, this is actually really, really concerning because these are the patients who are much higher risk of developing a stroke earlier. In the US, severe hypertension in the US, older Black female patients were at more risk for severe hypertension. And in the Netherlands, and you compare 1.7 per 100,000 versus 7.3 in the Black versus the white population. So much higher risk of having severe hypertension in the Black population. And the Netherlands might reflect what we're seeing in sub-Saharan Africa due to recent migratory patterns. And this is on the background of a rising proportion of people in sub-Saharan Africa developing hypertension. Now, what we see from these data are in 2000 versus 2010, a rising prevalence of hypertension in sub-Saharan Africa, as opposed to in North America, this decrease in prevalence of hypertension. By 2015, 75% of the world's hypertension population was living in the low and middle income countries. And so we need to actually address these problems within our environment. And it's not just the prevalence of hypertension, it's years of lives lost due to cardiovascular disease. So if you look at Africa, the lighter colors indicate more years of lives lost. So people are dying at younger ages from hypertension. And this is very tragic. And we see this in maternal health in women who've had hypertension during their pregnancy, developing these kinds of problems. And it's not just awareness of the blood pressure, it's awareness of the complications. And this was a meta-analysis that was done looking at people who were aware of hypertension as a risk factor for stroke, cardiovascular disease, and coronary heart disease, and really poor awareness when it comes to, do I have hypertension? So moving on to the treatment, and obviously we need to start off with lifestyle management. So first of all, we need to make sure that all the correct things are done. And basically this is a summary slide, and Lisa will talk about this now. So I'll talk about some of the treatment options that we have available. And these are the data from the Creole trial, an all-African study, 10 different sites across sub-Saharan Africa, and looked at close to 800 patients and split them into 3 arms: perindopril hydrochlorothiazide, amlodipine perindopril, and amlodipine hydrochlorothiazide. And what we notice is that the calcium channel blocker diuretic arm achieved blood pressure control within 2 months. Slightly later or slower with the calcium channel blocker ACE inhibitor, but the ACE inhibitor diuretic arm did not actually achieve blood pressure as good blood pressure lowering effect at 6 months, despite high doses. Unfortunately, the amlodipine hydrochlorothiazide arm was associated with low potassium levels, and 3.2 is pretty low. Angioedema was only at 0.7%. And then just talking a little bit more about diuretics, what we notice is the diuretic that we all have available and easily accessible to us is not as effective as chlorthalidone and indapamide, the thiazide-like diuretics that are available. So just to bear this in mind, when we are treating patients, we're not using the best bang for buck when it comes to the usage of hydrochlorothiazide. Moving on to the potassium-sparing diuretics, amlodipine and spironolactone are quite effective when it comes to blood pressure lowering, and these are fairly cheap and easily available and need to be considered. Eplerenone is slightly more expensive and so not as easily available, but these two are easily available and often of huge amount of use in our setting. I just want to mention that this is perindopril amlodipine or in amlodipine and indapamide combinations. Okay, so sorry, perindopril amlodipine versus perindopril and indapamide, and these were in diabetic patients. And the reason I'm bringing it up is they're actually pretty effective at both arms are effective at lowering the blood pressure with low side effects, even in a place like Cameroon. The other benefit, something that we need to start thinking about, is decreasing variation in blood pressure. And so indapamide and amlodipine are better at keeping the blood pressure within a narrow range, which decreases cardiovascular events in the long run. So something that people are quite scared about, and this is kind of the elephant in the room, is angioedema, particularly in Africa, is the association with angioedema, because we will say that, ACE inhibitors cause more angioedema. So this is based on evidence mostly on the use of enalapril. Within the first few months, 3 months usually, there was a much higher rate of developing angioedema in Black African patients when compared to other population groups. And obviously, ACE inhibitors was across the board higher compared to the other agents. So what did the Creole trial study show is, just to bear in mind, only 0.7% of those that developed angioedema in the entire trial, as opposed to the 5.3% that developed hypokalemia in the hydrochlorothiazide amlodipine arm. And whereas this in this diagram, it's fairly low. So maybe it's not something to be that scared of. I don't think we should be moving away from ACE inhibitors when it comes to the because we're too afraid of angioedema. This does happen, and it's not the only drug that causes an allergic reaction. It's angioedema. ACE inhibitor is not actually an allergic reaction. It's more, it's a direct ACE inhibitor effect. But yeah, just to bear in mind, this might be an overcall. And the other thing is that it seems that ACE inhibitors have better cardiovascular protective effects when it compares to some of the ARBs. So it is something that we need to think about, and probably something we still should consider using in all population groups. And then moving on to combination therapy, I really like this trial, which is a small trial looking at 4 different agents: amlodipine, atenolol, benriflumethiazide, and captopril, and comparing the full dose of these 4 agents versus a quarter dose of these 4 agents into a combination tablet. And what we see here is blood pressure lowering effect, and those reaching target was much better in the combination arm at the lower small doses of these 4 same agents. And when we see these combination agents, using them over time, over a 60-day period, you're achieving blood pressure lowering effect that is probably going to be sufficient to actually lower the blood pressure in the vast majority of patients. And we see it even more in those that have even higher blood pressures. And when it comes to the use of single pills versus combination agents, what we see is the more tablets patients take, the less adherent they are. And a combination tablet will have the benefit of just being able to monitor one level to monitor adherence. And so this is why the guidelines are recommending the stepwise approach with low dose combination, full dose combination, adding a 3rd tablet still as a single pill, and then only when you have resistant hypertension, adding an extra tablet. These guidelines from the ISH do recommend in Black African patients that you need to consider the use of a calcium channel blocker in your as part of your original agent combination. And they do make a provision that if we don't have access to these things, there are a bunch of agents, and whatever we do, we must control blood pressures. And the aim for blood pressure control is to achieve blood pressure control within a shorter period of time. So we need to make sure that we're achieving blood pressure control within a 3-month period. So now the ISH guidelines have given us these very easy stepwise approach that we can actually have available just to kind of run by in a drawer, on the wall, in clinics, in our offices, just, what's the next step if we want to refer to, because sometimes we do just need to refer to something quite easily. And these 2, what they've got here is in the blue is what we should ideally be doing. And then if we're not able to do the ideal situation, what we need to at least be doing. And they spell it out for everything. And this actually can be supplied to patients if we want to. So just bear in mind that this is a very useful tool. And the ISH guidelines of 2020, we have said are probably appropriate for the setting in the vast majority of situations. Well, Pascal has made this commentary saying that for our setting, this is probably a useful guideline. We don't need to create more guidelines. We don't need to develop individual country-based guidelines. We can use these across sub-Saharan Africa because it is appropriate for our setting. And so the summary recommendations for controlling, treating blood pressure is make the diagnosis at a definition of 140/90. You want to target a blood pressure of less than 140/90, at least 20/10 within 3 months, okay? And you want to introduce lifestyle changes to achieve these target blood pressures with 2 drugs to start off. So every patient should start off on at least 2 drugs. And this is going to improve blood pressure control and decrease hypertensive-mediated organ damage. And this is a very simple and effective approach. So how do we achieve control? Well, this is a multi-stakeholder interplay that really needs to be that everyone needs to be involved in. So we need to make sure that the correct medications are available, the correct people are available to provide medication for all of the for the entire population, and we need to make sure that our public has actually got access to the treatment. The World Hypertension League has spelt out what we need to do at all levels, but they were particularly focusing on Africa to improve blood pressure control and support hypertension control initiatives. We need to deliver effective care and support overall population control. And to do this, we need engagement with all actors in this game. That's government, partners in academia, communities, healthcare workers. And I believe that industry is actually part of this process. And as we move out of the pandemic, we need to think of what we've learned. We need to focus on some of the major benefits that we have achieved in the past couple of years. And this is improving access to telehealth and medication. And how can we use this to improve control in our patients? Like interactive text messaging, telephone calls, educational content, and smartphone applications. And these have been trialed and utilized in Africa. And in fact, Africa has been almost spearheading this telehealth or not even medicine, it's a telebanking, tele-everything, because this is easily available to a lot of Africa. And so we need to use this to make sure that we can actually start to improve blood pressure control and other cardiovascular disease control. So with that, I would like to thank everyone for listening. And that's the end of my talk. And we do need to reflect on the past and what in order to go forward.
Thank you so much, Erika. That was really interesting. Ladies and gentlemen, colleagues, please post your questions in the chat box and we will make time to discuss those questions a little bit later at about 6:45. It gives me great pleasure to introduce Lisa Ware to you. Dr. Lisa Ware is a senior researcher at the University of the Witwatersrand. She's also director of the WITS Health Hub. Lisa is a registered nutritionist and has published more than 70 peer-reviewed publications, and she holds a C rating from the NRF. Lisa, thank you so much for taking time out to share with us your experience. Looking forward to your talk.
Thank you, Marshall, for a great introduction. So, colleagues, I would like to talk a little bit around lifestyle intervention, as Professor Jones has just alluded to. So looking a little bit more about what that means within the South African context. So as Marshall indicated, my background is in nutrition and also health psychology and nutrition from the UK. I'm not a registered nutritionist within South Africa, but I do work in primary prevention and primary prevention research. So we'll start by looking at what are the interventions and then the evidence for their effect in low middle income countries, and then how these are applied within South Africa and who the patients actually are. Then we'll explore a little bit around the barriers that patients might face and how we as healthcare practitioners can encourage patient motivation to start with lifestyle interventions and to stay on track. So how much change in blood pressure is possible with lifestyle interventions? Well, according to these authors, effective lifestyle modification can lower blood pressure by at least as much as a single drug. But the key, I think, is the word effective in this. The guidelines do largely agree on what those modifications are and what they should be, and that these modifications can benefit all patients with hypertension and not just those who are overweight. And also that they should be employed at every stage, so in the pre-hypertensive stage, before drug therapy, and in hypertension on those who are both on and off medication. So what changes are recommended? So as we said, most guidelines are roughly in agreement. So definitely stopping smoking, changing to a healthy diet, so reducing fat intakes, reducing red meat, refined carbs and sugars, reducing salt, moderating alcohol content and lowering weight, and then increasing fruits, vegetables, and specifically low-fat dairy products. And this is the basis of the DASH diet. So the dietary approaches to stop hypertension. So these guidelines on the left, you'll see, were from the UK in 2010, and on the right is the South African Hypertension Society guidelines. The South African Hypertension Society, the nice thing is there is a clear target for what patients are aiming for with each of these categories, and also the expected change in systolic blood pressure if that goal is reached. What these guidelines don't give is an indication of how to deliver that. And if we look at the guidelines from the UK in 2010, there are some indications on how to deliver this. So they say we must give clear written and verbal explanations. We need to allow time for the patient to ask questions and discuss problems. Referral to a dietitian, a nutritionist, or an experienced nurse is important, with regular monitoring and feedback, and that we shouldn't underestimate the authority and credibility of the physician. So if we look at results from the Premier trial, this is quite an old trial now, but it was incredibly successful because they randomized patients to 3 arms. So one arm, this was done in the US, one arm was advice only, so 30 minutes with a dietitian or an interventionist, just giving printed material and having a discussion with a patient and no counseling. The second intervention was what they called established intervention, so weight loss, sodium reduction, increased physical activity, and limiting alcohol intake. And then the third intervention was all of the established plus the DASH diet. So this was 800 adults that were included if they had a blood pressure that was above optimal. So this was essentially the general population, excluding anyone with a BP less than 120/80. Nobody was on treatment. The mean age was around 50, and they described the population as generally overweight and sedentary. If we look at the effects of the 3 interventions, you can see at baseline, the hypertension prevalence in the group was 38%. In the group that just had the advice, that reduced to 26%. In the group that had the established behavior change intervention, it reduced from 38 to 17%. And where DASH was added to that, that actually went down to 12%. So it's quite a big effect. So if we look a little bit more at that, you can see in the advice only group, there was a small change in weight, fitness levels increased. The big change is probably the reduction in sodium. So you can see a reduction of 20 millimoles in 24-hour urinary sodium excretion. And the potassium stayed roughly about the same. If you look and compare that to the established intervention, then you can see in the established, there was a larger drop in weight, a slightly better increase in fitness, a bigger drop in the dietary sodium, and this had a bigger impact in the blood pressure among the whole group and also in the hypertensives. And if we look at where the DASH diet is now added, the biggest difference is probably the increase in potassium. So you can see that the urinary potassium has increased significantly. And that's not a surprise because DASH includes 9 or 10 portions of fruit and veg a day. I think they achieved maybe around 8 in this trial, which is a significant change. And then you can see in the hypertensives, particularly, the magnitude of change in the systolic blood pressure was very impressive. But to do that, they had 18 face-to-face contacts over the 6-month period. So that's approximately 3 visits a month for the 6 weeks, with counselling, group meetings, individual sessions. So it's quite intensive. So often in low middle income countries, we hear that, you know, resource is very constrained. So can we actually deliver something like that? Well, according to this systematic review, the answer is yes, maybe not to the same effect, but these things do seem to work. So behavioural counselling or dietary modification, encouraging physical activity, or multiple interventions can lower systolic blood pressure. But if I examine those studies from the low middle income countries, only 2 of those are from Africa. One was from Nigeria, which was testing a cycling intervention, and the other one was South African, and it was testing the supply of modified foods. So this was a study that was published back in 2008 by Karen Charlton and colleagues, where they recruited 50 to 75-year-old men and women from a township near Cape Town who were being treated for mild to moderate hypertension. The trial lasted for 8 weeks, and individuals were then randomized to either the intervention or the control group. So for both these groups, they had food delivered. The intervention was 500 mils of fermented milk, and then 6 key food items where the composition had been changed based on the salt used. So they used a low sodium salt, and you can see the composition here at the bottom of the screen. So it's around 40% sodium, 40% potassium. And then the control group just had the standard composition and cool drink. So with this, over the 8 weeks in the intervention group, they achieved a 6 millimeter reduction in systolic blood pressure. So even with delivering the foods to this group that were all mild to moderate hypertensives, they didn't achieve the same level as the groups in the Premier trial in the US. So inherently, there's something a lot more difficult about doing this in our environment. The great thing about these studies is they did lead to and support the implementation of the legislation around reducing sodium in a range of processed foodstuffs. And the early indicators are that at population level, this does seem to be working. But if we look at the data from the intervention trials, it certainly suggests that blood pressure can be lowered with lifestyle modification in low middle income countries, and that these interventions may even be cost effective. The challenge is the research studies that are published in these papers usually compare the intervention to usual practice. And lifestyle intervention for hypertension, as you heard from the previous speaker, is supposed to be usual practice in this country and in most countries. So we need more data on what's actually happening in practice. How is it being implemented and what effect is it having? And if we look for this data, it's actually quite difficult to find. So here is a study from 300 patient records at a community health centre in Joburg. And you can see only half of them had lifestyle modification even documented in their records. this is maybe not surprising if we actually look at what is happening in the primary care sector, because this study from the Eastern Cape showed that from 200 nurses across 40 clinics, half of the nurses were hypertensive and 41% of them didn't know they had high blood pressure. So the authors suggested it was because of stress and long work hours and shift duties and unhealthy diet, but that could probably be argued for a large proportion of the population. So who are the hypertensive patients? Does it matter if you have more income or more education? And the answer is no, or it seems to be no. So there's no socioeconomic gradient in the prevalence of hypertension. If somebody has more money or has more education, there is a better chance that they will be effectively treated, but they're no more or less likely to actually have hypertension than someone that doesn't have those resources. However, if someone doesn't have those resources, they are more likely to have these behaviors that are less of a choice and have less flexibility and less capacity to change the behavior. And if we look at the South African context, it is an incredibly difficult place to make these changes. The changes are hard anyway, but I think here we're battling uphill. So a third of South Africans apparently will be obese by 2030, according to the World Obesity Federation. And obesity is a very normal situation. It's becoming a very normal way of life here. The sodium legislation, as I mentioned, seems to be working, but we've got a long way to go, and the potassium intakes are still low. There's high crime, violence, and high stress rates, and we've published showing that psychological distress actually predicts the development of hypertension in people that have normal blood pressure. And also, only 37% of our working age adults are in employment. 70% of those don't have medical aid, and 1 in 4 doesn't have paid sick leave. So engagement with primary care can be very challenging. And also neighbourhood safety is a big issue. So that's going to impact how somebody feels about exercising in their local environment. But safety is not necessarily the only consideration if we think specifically now about physical activity. So there's 2 graphs here that show recordings from a wrist-worn accelerometer. So each of the peaks that you can see represents movement. And on the top graph, you can see this is now somebody that works in an office. And there are clear periods in that day where we can see that activity could be increased. And the bottom graph, this is somebody who works in manual labor. So this could be domestic, this could be cleaning, this could be landscape gardening. But where does this person increase physical activity in their day? From the minute they wake up to the minute they sleep, they're already moving. In fact, even sleep is more disturbed. If we look at the diet here, this is data from 2015, where we conducted a countrywide survey collecting 24-hour urine samples from across all the provinces. And when we analysed that data, we saw that almost half of 18 to 49-year-olds had almost double what the WHO recommend in salt intake daily. And that is associated with an increase in blood pressure across age. 91% of adults failed to meet the requirements for dietary potassium. And the impact of that, those 2 things combined, means that 1 in 5 of our adults are having 5 times the level of sodium to potassium ratio in the diet. And a ratio above 5, so 5 times as much sodium as there is potassium in the diet, is related to a 5 millimeter increase for every 10 years. So we need to really shift this balance and find ways to do this between, high sodium containing foods to higher potassium containing foods. But the reality is this is not easy. The perception is these healthy foods cost more. And if we look at the data around this, certainly people believe that healthy food is more expensive and food purchasing is driven by income. But when you look at the food options that are available in places like Khayelitsha, healthier food options are more expensive than the less healthy equivalent. So again, it's a big challenge for people to make these dietary changes. There are increasing numbers of salt substitutes coming onto the South African market. And these different products have different levels of sodium and potassium. So typically the sodium is reduced and the potassium is increased, and there may or may not be other electrolytes in the product. But again, they cost twice as much as the usual salt. However, there's some interesting data coming out from some very large studies now on how much impact a low sodium salt can have on cardiovascular outcomes, and also safety data for these type of products. What about perceptions of obesity? This is something also we're battling. So if we look in 2010, this is young girls living in Cape Town, and the girls thought that, you know, being obese was associated with positive things, and that weight loss was actually seen to be unhealthy. In 2018, if we again look at the attitudes and the perceptions of young girls, we're seeing still positive attitudes towards obesity, but we're also starting to see some negative attitudes. So perhaps this is starting to shift. And then, as I mentioned, you know, psychological distress can cause hypertension over a 5-year period in normotensives. And I think there are new interventions, you know, being explored that may help with stress, but of course, depending on the source of the stress and whether, you know, more serious referrals are needed. So how do we understand how to support patients and to keep them motivated on this journey when the challenges are so great? I think the key thing is to explore where patients are at. What do they understand about blood pressure? What do they understand about the impact of the blood pressure for them? Is it personally relevant? If it's asymptomatic and they don't feel anything, what is the motivation to change? And then what is their capacity to change? And this will determine whether the conversation then is about one domain or multiple domains in behavior change. There are a number of resources for behaviour change support for both patients and for healthcare practitioners, and I've put links to these in my last slide. And I think the lifestyle intervention is currently on the guidelines as a treatment. It should probably also be there as an evaluation to understand where people are and to help them make a plan to get to where they need to be. So people are experts in their own lives. We don't need to be an expert. They're the expert in their own life, but their plan has to be smart. So they need to be able to come to a place where they know what they're doing, when they're doing it, how long they're doing it for, when they're going to evaluate that, how they're going to evaluate it, and what they will do next, and how they know if they're on track or they're not on track. We need to ensure that regular monitoring is possible, and ideally self-monitoring. If somebody doesn't have weighing scales or they don't have a blood pressure monitor at home, what are the options for ensuring they have access to that, maybe through a pharmacy, or if a community group can hold that equipment? And then record and audit the outcomes of our usual practice and publish that. What is the impact of what we're doing? What are the success stories? What does work and what are the continuing challenges? And then lastly, consider the health of the healthcare providers themselves. Behavior change isn't easy. And patients need to know why they're on this journey and that it is their own journey. They need to see if they're being successful and what change they're having. And we need to congratulate them for every step because it is particularly hard here. These are the number of resources for patients and for healthcare professionals, including some quick tips for supporting behaviour change conversations and how to understand where patients are currently at. Thank you. Ngiyabonga, Kieleboha, and Kozi, and thank you.
Thank you so much, Lisa. That was very interesting. Colleagues, we will now have the discussion session. I've received some questions so far, but please feel free to send us more questions and I will address them to the speakers. I think, Erika, we'll start with you. The first question we have is, where do beta blockers come into the treatment of hypertension?
So over the past kind of 15 years, the beta blockers used to be the traditional start off for treatment with the diuretic, but this has changed considerably. And actually they fall into kind of fourth, fifth line nowadays. And there's certain population groups where you do want to avoid them, particularly the older population groups. There are some specific indications for beta blockers. Obviously, cardiac conditions do require beta blockers. And young women who may be planning a pregnancy, they tend to be safe. So you might want to consider a beta blocker. But for the vast majority of patients, beta blockers will fall into your kind of fifth or sixth antihypertensive that you might be considering using.
Right. And when would you consider combining the beta blocker with an ACE inhibitor?
I would combine it with an ACE inhibitor when I'm considering treating a patient with heart failure, or someone who's got a tachycardia that you really need to want to try and control that heart rate. And Marshall, you're probably the better person to discuss that.
Yeah, that's a very interesting point because, you know, of course, the other question is, especially in Black patients with so-called lower renin levels, question is if, you know, their RAS system is less active than those without lower renin levels. What's your take on that?
So I think that there's enough physiological evidence, certainly from the Northwest University. They've come out with a lot of evidence really demonstrating this across age groups. And I think it is very relevant. And that's one of the reasons why we see the data from the Creole trial, where you're seeing this differential response to antihypertensives. But we do know that when you're trying to manage cardiovascular disease, LVH, proteinuria, RAS antagonism really is of benefit. So we still need to consider the RAS antagonists as part of our armamentarium for blood pressure control in Africa.
Fantastic. Lisa, I have a question for you as well. What do you think might be the easiest behavior modification to adopt for hypertensive patients? You can just unmute yourself. Good, thanks.
Thanks, Marsha. I think it's a very good question. I think everyone is looking for a quick fix. I think it depends on where the patient is at currently. Probably one of the least intrusive is the low sodium salt. That's a very simple switch. And I think the evidence is really growing for some of those products, but we've yet to try that in Africa. I think the trials are just about starting.
Right. So it's quite of a problem if your patient has chronic kidney disease and you now want to switch, you know, you want them to maybe switch to potassium substitutes. What would you recommend in that situation?
I think it's something to be mindful of. Certainly the data from Bruce Neal's study in China, they tested a 25% potassium chloride product in almost 21,000 Chinese participants. and found no more adverse effects of the product than they did in the normal salt group. So I think it depends on the potassium level of the product that's being used and also who the patient is, but it's certainly something to consider.
Right. And then how can we as healthcare professionals communicate the importance of changing behavior? You know, we see patients and they swear they're going to do this now and they're well motivated, but when they come back 6 months later, same problems. What can we do to motivate them?
I think, and again, it comes back to the patient's understanding what is their personal relevance of the two numbers that they are being given. Does it mean anything to them? And finding, you know, what do they know and what is it that would motivate them? Perhaps they've got a family history of stroke. Perhaps they've got, you know, siblings that have diabetes, and making the link between blood pressure and diabetes might be something that creates that motivation. I think it's just understanding where they're at and what is the thing that is going to hook them.
Right. Erika, there's one more for you here from Javiva. Do you have any concerns with beta blockers being diabetogenic, especially in Black patients?
This is a huge concern, and this is one of the reasons why it does fall from, damn it, I've forgotten the name of the trial. Major trial came out 2006, and it really just moved us away from the use of beta blockers and diuretics through to the use of calcium channel blockers, ACE inhibitors. And the big reason is they're diabetogenic, especially in combination, and definitely something that we have to be concerned about, because we don't want to be giving our patients, it's a very, very unfriendly disease, diabetes, and we really need to make sure that we're not contributing to it as best as possible. Obviously, if it's all we've got to do, then, well, we kind of have to weigh up the pros and cons. But yes, that's why we're going for ACE inhibitors, calcium channel blockers, thiazide-like diuretics possibly have a better profile than the thiazide diuretics when it comes to metabolic complications. So these are the reasons why we need to choose these agents rather than going for the beta blocker diuretic combination.
And is that specific for atenolol, or does it include all the beta blockers, the diabetogenicity?
You know, atenolol is the one that's been most studied in. I think that I think there may to some degree be a class effect, but this needs to be kind of really explored. Possibly the newer ones are less effective in this, but in some ways it's understandable that it's going to be a class effect, because it's a beta blocker effect, which is going to affect your insulin uptake, which is going to lead to increased risk of diabetes. So it makes sense to me that it's a class effect, but I don't know the evidence around other beta blockers.
Right, and then of course there's always this issue of erectile dysfunction. Question from Chabuzo: what is the relationship between antihypertensive and erectile dysfunction, and which antihypertensives poses that risk, and what is the management plan for such a patient?
So first and foremost, the people that get hypertension are already at risk for erectile dysfunction because it is a vascular disease, as is hypertension. And so controlling blood pressure is vital in trying to prevent erectile dysfunction, as is controlling diabetes. So, I mean, obviously, if we can do it with all the lifestyle changes and correct our lifestyles, preventative therapy, that would be best. I mean, if we could reverse our jobs, you and me, Marshall, if we could be out of jobs, I think I'd be happy for the population. But unfortunately, it's not. Life's too easy and happy with all the bad stuff that we enjoy. So we have to deal with the consequences. And one of the consequences is erectile dysfunction. Having said that, yes, there are antihypertensives that contribute to increased risk of erectile dysfunction, and it's particularly beta blockers are renowned for this. The other age, I mean, some say that anything can do this, but as far as I know, the RAS antagonists do it to a lesser degree, possibly calcium channel blockers to a higher degree. And this is one of the reasons why you want to control blood pressure at an early stage and achieve it with low doses, because then you're less likely to have complications and side effects.
Right. Lisa, there's a question for you as well. How can I, keep my patient motivated? How can I, he's getting there slowly. How can I keep him motivated? With the lifestyle interventions, of course.
I think the critical thing is monitoring and feedback. So, as I mentioned, people need to have a way to see how they're doing, and feedback. I think, as Prof. Jones said, technology is really giving us different options now to do things differently. WhatsApp support groups, where people congratulate each other, or where people link with healthcare professionals, may be a simple option. Or even, community groups to encourage people to stay walking, so they create those social connections. I think those are the things that really keep patients engaged, is having that social connection, the monitoring and the feedback.
Yeah, that's, my personal experience is hypertension is a curse for life. You have to take these medicines for the rest of your life. And if you stop taking them, you stroke and you die. So that was where I grew up and what I personally experienced. And, to keep my patients motivated, I tell them my life story, and if they don't do that, and it's just about making simple changes to your lifestyle and sticking with it, of course. That's so important. I think, people, especially diabetics, I mean, if we look at the list of medications that they have to take, it's probably 10, sometimes 12, 15 drugs. And then you ask yourself, how many of these do they take sometimes? Do they take them all the time? Does it differ weekends when they drink or the Springboks are playing? It's just, it's just so difficult. But I think it's about accepting your condition and living with it and controlling it. And that's really also what the focus is of tonight's discussion, is that home blood pressure monitoring will be an option for the patient, to take ownership of their blood pressure. And thank you so much. I think our discussion will have maybe some time a little bit later. But ladies and gentlemen, colleagues, it gives me great pleasure to introduce to you our friend, Professor Brian Rayner. Brian and I have had many debates before on hypertension and drug management. Prof. Brian, it's really a privilege for us to have you here. You all know Prof. Brian. He was the previous head of the SAHS Society, and Prof is now retired. He's emeritus professor, but still continues to do research. And I found it interesting that Prof was also interested in the genetics of the Khoi people and their management of, the sodium management of their kidneys. Prof. Brian, we're really looking forward to your talk entitled Hypertension, an Update on Evidence-Based.
Sorry. Okay, good evening, ladies and gentlemen, colleagues. I'm going to talk to you about the diagnosis of hypertension, which is a really critical issue that we need to address, and the new developments in measurement of blood pressure. So we've talked a lot about hypertension, and this is really a critical problem in sub-Saharan Africa, if you heard. It's the #1 cause of death in 2010, and the prevalence is rising. 500,000 deaths then, a lot of comorbidity from hypertension. It's a much more serious disease in African people, and you need to be measuring their blood pressure much more regularly to diagnose hypertension. So it's now currently about 40%. South Africa has one of the highest prevalences of hypertension in the world. And we have this 91% unmet need. And this is largely driven because people do not know what their blood pressure is. It's not been measured, they've not been told about it. So, you can improve treatment, but reality, we need to diagnose more patients. But we don't want to misdiagnose them. We want to diagnose them correctly and not convert normal people into hypertensives when they don't have the condition. And my great friend and wonderful colleague, I really mourn him, Professor Bongani Mayosi, said, best to combat heart disease, diabetes and stroke in Africa and kidney disease is number one is hypertension. Highly cost effective. We have generic drugs that can manage this condition very well, provided they take this therapy though. Now we need to know what we mean by hypertension. And this has recently come in the central diagnosis from the World International Society of Hypertension. And we must reflect that hypertension is a threshold of 140 or 90, okay, diastolic. That's grade 1 and grade 2 here. They don't have grade 3. I must admit, I prefer to have this because we see this a lot in South Africa and signifies a patient at extremely high risk. But remember, we have this high normal category, 130 to 139, not a benign condition. These people need to be monitored and intervene with lifestyle, particularly. Drug treatment is not necessarily indicated. So it's important to actually get this correct. And why is there so much attention to blood pressure measurement? Well, it's absolutely one of the king of prognostic markers for cardiovascular disease. It's essential for diagnosis and essential to determine blood pressure control. So if you're not doing it accurately, you're kind of wasting your time. So we need to improve our performance on blood pressure measurement. And 22 years ago, when I went to a workshop and I got my certificate of achievement to measure blood pressure, I wonder how many of you, and if you look at this, what I'm wearing was the hypertension team jacket that they gave us 22 years ago, which I still wear. And so just remember, and a lot of people are not measuring blood pressure correctly. So nowadays, we've got a lot of options to measure blood pressure. We've got the standard manual auscultatory method, either mercury or aneroid. And some have decided that the mercury in the manometer is extremely dangerous and they've been banned from many countries. And the aneroid devices with the dial. Then we have electronic devices. And then we may have a concept of automated office blood pressure, which I'll come back. And then we have home blood pressure monitoring. That's an important development and a highly useful development. And please remember, only upper arm devices. The wrist device should only be used in people who are so fat you can't get the cuff around their upper arm. And then there's 24-hour ambulatory blood pressure monitoring. So the clinic blood pressure is an artificial sentence based on a single heartbeat, and we do it once or twice a year, and we think of the quality of blood pressure control. So you can think of an analogy to monitoring sugar. We don't just do sugar in the rooms twice a year and determine diabetic control. That's what we used to do. Because, you know, you want something better. You want an HbA1c, which tells you what's happening for 3 months. You may even want continuous monitoring of blood sugar. So you improve the idea of what's happening in your patients. And people don't usually have strokes and heart attacks in your rooms. And we often have a poor appreciation of the usual blood pressure in their normal daily life. So we don't want to treat those that don't need to be treated, and we want to treat those who need treatment. And who needs treatment? Patients with unequivocally elevated blood pressure. And also, when you decide to treat, you can treat a person, convert a patient to a person to a patient, and you potentially give them side effects of medication. And if they don't require treatment, they're not going to like you with their erectile dysfunction. By the way, Viagra is very, very useful in hypertensive patients, in my opinion. Okay, so this is a traditional method we used, the arm supported with the doctor, and there's a lot of problems with this methodology, a lot of errors. One patient once when I was working in Durban complained to me that didn't mind the doctor not getting out of his chair to do things, but they would mind him plugging his stethoscope into his ear when they're examining him and doing the blood pressure. So there's digit present, there's bias, there's hearing, there's cough, there's lack of servicing, clogged vent, anxiety, obesity, arrhythmias, all sorts of things can. And in fact, this is a systematic review of the error in blood pressure if it's not done properly. From -23 to +33 systolic, that's enormous, and -14 to +23. And we did a survey in a community health in Cape Town and came to very similar findings. So when you measure blood pressure, you might have the conditions, position, the setting, usually in your office, body position, seated or back supported, no talking. The device now recommended by the ISH is a validated electronic upper arm cuff. And this is where you get the organizations will tell you whether these are validated or not. You can still use the manual method, but it's alternative. Make sure you have the cuff size. And to diagnose hypertension, you need 2 to 3 measurements. You take 2 or 3 measurements on 2 to 3 office visits, unless the blood pressure is severe, above 180/110, that you may break away from this protocol, or you find with the elevated blood pressure overt hypertensive mediated organ damage. So this is a position seated with the arms supported at heart level, the correct cuff. Too small elevates the blood pressure, too large undercuffs, bare arm, back supported. No talking about the politics in South Africa and what's happening in the country with corruption, feet on the floor. And you need to have repeated measurements. This is an essential way. And I suggest that you don't use if you're going to use the automated monitor, you don't get one that patients use. You need a more durable machine like an Omron 808 that is much more useful and durable for using in your rooms. So when you've taken the blood pressure, if it's less than 130/85, remeasure in 3 years, unless the patient is black, then you do it annually. 135 to 89, possibly confirm with out-of-office measurement, but you can do with repeated office measurements as discussed. If it's much higher, you want to speed up the process and getting confirmation that there's hypertension present. But the problem is, white coat hypertension. That's the elevation of blood pressure in the doctor's office occurs in about 20 to 25%. And now masked hypertension, which is a normal blood pressure in the office, and an elevated blood pressure out of office. And so you can get it wrong in 30 to 40% of cases. I mean, if you were doing cholesterols or fasting sugars and said, well, there's an error in 30 to 40% of cases, you'll be scratching your head. So you can be more confident if the blood pressure is very low and the blood pressure is very high. And this concept of white coating is here. In the office, it's above the level of 140. But if you measure it on ambulatory or home blood pressure, it's below the threshold of 135. Normal tension is when both are not normal. Mask is where it's normal in the office and elevated outside, and so-called true hypertension when both are present. So this is schematically normal, it's true normal tension, normal office, ABPM, and you must read home blood pressure the same as ABPM. Office up, normal ABPM, white coat, normal office, increased ABPM, mask, and both elevated true hypertension. So the white coat hypertension becomes beginning of this, and I tell you, you just cannot identify who's going to white coat on you. I mean, it's just, you can have a bias, but really you can't identify the person. It persists for 10 to 15 minutes, be high as 27/14. I've seen higher elevations for the first 2 to 4 minutes. It varies considerably. It doesn't easily fade in time in the clinic. but it's not generally associated with cardiovascular risk. But you'll come back, there's a lot of controversy about that. But it also can occur in your hypertensive patient, and this is a white coat effect with pseudo-resistance. Example of the pseudo-resistance is in the Harvard study, where they did the sitting systolic blood pressure 172, and the ABPM was 140. And this white coating is often more exaggerated, in my opinion, in elderly folk who have stiff arteries. And an increase in heart rate it's an exaggerated systolic response. And I think one must be much more careful in the elderly folk. Now, what people have looked at this, what is it? The prognosis, look, normal people with normal blood pressure also have heart attacks. They may have diabetes or hypercholesterolemia or other reasons. In white creatine, they say there's a minimal increase. Uncontrolled hypertension is a bad effect with more cardiovascular events, and mild hypertension even worse, probably because it remains undiagnosed and untreated. However, Mancier is not of that opinion. And he says, if you have a white coat hypertension without any evidence of target organ damage, these patients are increased cardiovascular risk, increased mortality, increased developing cardiac and renal damage, and greater chance of developing sustained hypertension. And the cardiovascular mortality is in between normotension and sustained hypertension, and the same as all-cause mortality. So this is clearly, from his perspective, increased risk. So there are issues. However, I look at it this way, and we need to really look how we define white coating a bit more clearly. Because remember, risk starts at 115/75. If you're 135/75, you have a double risk of a cardiovascular event. Just remember, we haven't established treatment in this level, other than we advise lifestyle, we don't generally advise drugs. So if you look at it here, if you have a normal blood pressure and kick your blood pressure 25/10, you may well get into the hypertensive range, but you have a truly normal blood pressure. But if you kick your blood pressure from 130/85, which you're diagnosing as normal, to 145/95, this is two different animals, in my opinion. And so this is often the difficulty. And in this study, they looked at these varying thresholds of white coat and masked hypertension population. And they came to the conclusion, if you just took the daytime, which is usually the definition, that the daytime is elevated, not elevated in the white coat, but at nighttime. But if you actually take all components together to make sure that the white coat in all three sections, then there's no increased risk. Masking, there is increased risk, but if you apply even more stringent criteria on this, as I've described previously, in fact, the risk is lower than a hypertensive patient, and including masked hypertension. So these are the controversies, and my take on it is, don't dismiss a white coater that you've diagnosed. Continue to monitor them, look for hypertension mediated organ damage, and so on, and deciding what to do. But all of them should definitely follow some form of lifestyle modification. Another way to get around the white coat effect in your office is if you have a separate room and a table, you can put the patients there away from you with an Omron, a MicroLife, whatever you use, and measure the blood pressure away from yourself and take 5 readings. We do this at the hypertension clinic risk here, and have them printed out if it's available, or they're written down by your secretary. And so it helps avoid white coating. And the cutoff is lower than 140/90, 135, and can be used for diagnosis and follow-up. There's a lot of controversy about this. The Europeans don't like it. The Americans love it because their studies like the SPRINT and the ACCOMPLISH were based on this methodology. And certainly, I think it's a highly useful technique. Saves you a lot of time in your rooms if you have availability. And again, you use a calibrated monitor as described. Thank you. I remember when you're using automated blood pressure, That's a cutoff for hypertension, 130/85, normal below 130/80. But you remember, optimum levels are below 120/80. Just remember that. Now, coming more to ABPM, we now know this is a relationship of conventional blood pressure and cardiovascular death. ABPM, and same with home blood pressure, that is the risk if you use the daytime. This is the risk if you do 24. And nocturnal blood pressure predicts the highest risk, okay, of a cardiovascular death. And you can see it also correlates. This is office blood pressure with markers of hypertension-mediated organ damage, which one is LVH, and one is the albumin excretion rate. Office blood pressure does correlate, but home blood pressure correlates much better, and ambulatory blood pressure correlates much more, has greater correlation with target organ damage. So the International Society of using an optimal situation, you need to combine out of office with office blood pressure. So you can use home blood pressure monitoring, and this is actually much more flexible because the ABPM is really a once-off process. You do it over a 3 to 7 day period, taking 2 to 3 blood pressures, and average the last 2. And for follow-up, you can take 1 to 2 management a month, and ask the patient to make a spreadsheet for you. It's very, very useful. And over a 7 day period to diagnose hypertension, exclude the first day. And if the mean is above 135/85, you indicates hypertension with a strong probability. The ABPM is more accurate, more blood pressures, day and night. Again, a validated device. And again, these are the criteria. Overall, 130/80, daytime 135/80, and nighttime 120/70. And you may need to look at all aspects of the ambulatory blood pressure monitoring. So this is a format. Somebody had elevated blood pressure readings done somewhere, pharmacy and office. You do your physical examination and diagnostic tests. Remember to do diagnostic tests because you must look for hypertension-mediated organ damage. If the blood pressure is above 180/110, you almost certainly have hypertension. If the office blood pressure is greater than 140/90 or the automated office is greater than 135, if not, you probably don't have hypertension. If yes, they recommend the ambulatory blood pressure monitoring or home blood pressure monitoring diagnostic series, as I've discussed. And so home blood pressure is valuable for diagnosis and evaluation treatment. And as we said, can be done over 7 days, usually 14 days is a bit excessive. Take 3 readings and let's take the last 2 stable readings. And just avoid decisions on ad hoc decisions when patients are feeling anxious. They must do it morning when they wake up before they take the pills, or if they're not on treatment before breakfast and in the evening. As for ABPM, as we said, it's a much better predictor. It's now become the reference standard in clinical practice with the uncertainty of the diagnosis, improved specificity and sensitivity of the diagnosis, and maybe avoid treating 25% of people who have white coating. And this is actually standard of care in the United Kingdom. So here's some monitors for you to see, normal tension. You can see some in this profile will have slightly elevated blood pressure, but the mean is in the normal range, and it dips at night by about 10% or more, okay? It's normal. And just remember, again, these are the levels, but look at the optimum levels. Be careful. Those are optimum levels. Those are normal. Those are in the category you mustn't dismiss and advise patients about lifestyle. And you can see people do misinterpret these. Here is a report from a specialist that says normotensive. And you can clearly, this patient is mildly hypertensive, 137, you can see, and the nighttime is actually just below the point of defining hypertension. So you may not wish to treat this patient, but definitely this patient requires monitoring and lifestyle. because the patient is not normotensive. They are borderline hypertensive or hypertensive. This is the white coat effect, and some programs on the ABPM will exclude this period, called the white coat period, and do the monitor for 25 hours so that you avoid this influence of the white coat. There also the non-dipper, who doesn't dip at night. It's a bad prognostic sign, and it's often seen in patients with kidney disease and back patients, diabetic, and so on. And whether you treat these patients at night with some drugs is unknown, but it may, but definitely you must use 24-hour blood pressure drugs, 24-hour acting drugs. In fact, we found in our kidney clinic and our transplant clinic, we're often giving totally normal clinic blood pressures and had markedly elevated blood pressures at night, often because what we have in the state are short-acting drugs. So be careful. And the non-dipper, as I said, CKD, black aphrin, diabetes, HIV, associated with adverse cardiovascular outcome. Use 24-hour drugging. If they're shorter, you must use BD dosing. So, and that's a problem with adherence. And this is the one you may recognize. This is a normal. So this was a form of masked hypertension, totally normal in the office during the daytime when you measure it, and it kicks at night. And that could cause sleep apnea or chronic kidney disease and it's a form of masked hypertension. And although nobody knows what to do with them from clinical trials, I'd certainly dose people at night and investigate this aspect like sleep apnea. This one is a really problematic, often seen in very elderly, frail people, very variable blood pressure, and then it crash at night, often with stiff arteries. How you treat this is difficult. Maybe this is one case with short-acting morning doses. I don't know, but you'll see this from time to time. Just remember, these extreme dippers are associated with more cardiovascular events, and dippers are better off, and reverse dippers are certainly worse off as well regarding presence of cerebral infarcts. So the place of 24-hour blood pressure and home blood pressure monitoring, diagnosis of hypertension, low risk, no target organ donor, blood pressure below 160/100. I think that'd be a useful place to use it. Normal office, but you've got dealing with a high-risk patient and the kidney function is not quite normal, they're obese, maybe underlying diabetic. I would think I'll do a 24-hour blood pressure monitoring. If you have an uncontrolled hypertensive, you may have pseudo-resistance, a white coat effect on top of it. And this is a very useful strategy to do 24-hour blood pressure monitoring. And if they're on just single daily dosing, maybe a good idea to actually do an adherence test at the same time by giving them medication just before you add the monitor. Assessment of control in high-risk patients and also patients are symptomatic with postural symptoms. Maintenance of the device, avoid sunlight, avoid fiddling with your device, avoid dropping it, avoid cleaning it with toxic materials, pouring water on it, clean it nicely with a soft, moist cloth with neutral soap. And calibration, this is a real big problem. The mercury is sort of kind of needs much less calibration, but automatic electronic sphygmometers sometimes produce systemic errors in some patients. So they should be checked and calibrated in a accredited laboratory at least annually. The other option is just to replace it every annually or every 2 years, because it's difficult to find these people to calibrate. Aneroid sphygmometers use the dial, the one with the dial. They have to be calibrated every 6 months because those little gears in them become worn down and becomes inaccurate. And only use validated sphygmometers should be used as per website. So in conclusion, it's important to standardize and measure blood pressure accurately and correctly. Office blood pressure is still essential for diagnosis and management of hypertension. Automated office blood pressures is considered important in reducing white coating. Out-of-office blood pressure monitoring is considered optimal for the diagnosis and management of hypertension. So you include all three methods. people with white coat hypertension need to be monitored regularly, and in those who are white coating, at the very least, I think you should modify their lifestyle, to monitor them carefully. And of course, knowledge of the normal values is essential because they differ between office and automated and home measurements. Thank you very much for your attention.
Thank you very much for the interesting talk. Professor, would you care to take some questions from that was posted?
I'm happy to, and I've also got some polling questions for the audience.
Good.
Okay.
I think we'll quickly just address the issue of nighttime dosing. You know, the Heradien trial. Can you just maybe tell the audience a little bit more about that, please?
Okay, there was a study in Spain that was done with nighttime dosing, which showed actually quite spectacular reductions in cardiovascular events. Actually, almost too good to be true. The one problem I identified with the study was that the patients weren't randomized. They were allocated. Whatever allocated means in a study is difficult to know. So it's difficult to know. The study is under a lot of scrutiny. Certainly it meets some of our preconceptions that nighttime blood pressure is important, and it may be valid. I don't know. I mean, there's been a lot of critique of the study. So we need more information on this. And the same guy did a similar study in diabetics and also showed benefits of nighttime dosing. My view is still, please use 24-hour directing drugs. You know, that's really important, that have a long half-life. So you cover the nighttime period. The problem with nighttime dosing, unless you're highly motivated, people miss the night dose. That's one of the problems. I mean, some people are very meticulous and they take their drugs, you know, almost obsessively. But nighttime dosing is the one that is often missed. Morning dosing is easy because the morning is more structured. The night is not. So those are the issues about it. I certainly see, if I see a patient certainly who has a non-dipping or reverse dipping, I will give one of the drugs. And I work in the state sector because we don't have a single pill. I give one of the drugs in the evening. That's my practice, but it's not currently accepted as a true evidence-based strategy.
Sure. There's a question from Kabasele. Once daily treatment has been encouraged for compliance purposes, is it the best way to keep hypertension under control?
As far as we know, I mean, as far as I know, that once daily with long-acting drugs. I mean, if you look at Ascot's study, they used long-acting drugs, and maybe that was the reason why it beat atenolol hydrochlorothiazide hands down. You know, a broad range, because perinapral and amlodipine are long-acting drugs. So the same with indapamide. It's a longer-acting drug than hydrochlorothiazide. Atenolol may give bad results because it's short-acting. You should give it BD. Enalapril is a BD dose. So, you know, these are the things that play in the mind. But I think these sort of type of things you often see in patients who like need a single pill in the morning and maybe use one of the pills, you know, at night. Only if I see really significant reverse dipping diet.
Right. There's a question from George. He said, if you listened correctly, Prof, did you mention calibrating the automated BP machines that you get from clicks or the pharmacy shops yearly? Is that correct?
That is a recommendation, and I don't think the clicks machines are actually on the Stride website. I very much doubt it. If that is the case, I think that we have to do this for our clinical trials. My personal view is use them for 2 years and then replace them. And I've picked up now where patients have had these devices for years, and they come with these weird readings, and it's I've heard they've been using the same device from 10 years from clicks. So, I mean, I don't have the study. I don't think these people put their devices up for calibration, you know, with the British Hypertension Society, and actually gone through the protocols, because it is expensive. So if you want to get a cheap machine, They don't go through the calibrations. I don't want to malign the machines, but I certainly think using a properly, I've personally found the ones that are on the website are the ones that tend to work much better, and you have the least problem. And certainly, I suppose I shouldn't be using brand names, but the sponsor's brand is a very good brand of device. There are others like MicroLife and Bosso. They're a good brand, and they're often on the website.
Right, thank you so much, Prof. Can we maybe go ahead to do your polling, and then we can see the response from the participants? Thanks.
Okay, the first question, as a healthcare practitioner, are you happy with the use of electronic devices to measure blood pressure in your room? Okay, so the vast majority are, but there's a significant percentage, 18%, who are not happy with electronic devices, and perhaps they can share on the chat why they're not happy with electronic devices in the room. Okay, next one. So it's 82% yes. Okay. Are you using home blood pressure monitoring as an adjunct to office blood pressure? Yes or no? That's the next question. And this, I don't know why the ambulatory blood pressure one is coming together. Maybe they asked the same question together. Okay. You've got to answer two questions. Okay, so 71% are using home blood pressure monitors as an adjunct. I personally think it's an essential adjunct to help you. Obviously, there are some patients you must avoid it in. But 29% are not against it. And ambulatory blood pressure, I thought this would be similar, is the 50, well, actually only 45% are using it. 55% are not using it. I think that's a fair assessment. I think more people should be using it, but provided you're using home blood pressure as an adjunct, I'm happy with that answer. Maybe people can share the experience of ABPM on the chat. Are you using single pill combination to initiate therapy? So that's in the patient who clearly meets the criteria for single pill, that the blood pressure is not just borderline, that is, established hypertension. Okay, 57% are using single pills and 43% are not. That's the current recommendation for patients with established hypertension, virtually by all guidelines. I see 43% are not. Sometimes this may be driven by medical aids and plans and so on and so forth that you are forced to prescribe a type of step care approach. But I still think you need to think about, even if you're not using a single pill, to do 2 drugs at the same time for the patients with more established hypertension. Definitely if their blood pressure is above 160/100, because you will not achieve blood pressure control in a single drug.
Thank you so much for that, Prof. Colleagues, we've come to the end of our meeting. Thank you again to Omron for the unconditional support. Thank you again to the faculty for sharing their knowledge. Just a gentle reminder to please register for the Hypertension Congress, which will be held in Sandton 16 to 18 September this year. For more information on the Congress, please visit the hypertension.org.za website. Thank you once again all for attending. Enjoy the rest of your evening. Looking forward to our next meeting. Stay safe.